many branches for the group, maybe 5 or 6 branches in Saudi Arabia and also in Emirat in Dubai city, and also in Egypt in Cairo. Today, I would like to introduce our professor, Professor Max Highland, oral and maxillofacial surgeon. He is a head of department of the oral and maxillofacial surgery in Berlin University in Germany. Professor Max, he had more than 25 years experience in our oral and maxillofacial field. Also, the panelist, Dr. Kamal Salim, oral and maxillofacial specialist, SGH Jeddah. Dr. Mahmoud Abu Saud, also oral maxillofacial surgery specialist, SGH Riyadh. Dom Vargas, the oral maxillofacial specialist in SGH Dubai. Please, our respected audience, write the questions in question and answers section, which is available on your screen, and we'll discuss these questions after the presentation. Please, Professor Max, we can start your lecture.
Thank you very much, Professor Mossen, for the nice introduction. Dear colleagues, it's my pleasure to share this webinar tonight with you about oral surgery and dental implants in patients with risk factors. I'm visiting the Saudi German hospital groups regularly since many years, and it has become like a strong connection and some kind of friendship to these colleagues in Saudi Arabia and in Egypt. So in these special times, it's my pleasure to join you by using virtual networking. And so now we will start my presentation. Wait, my screen. And here it should, you should see this now.
Yes.
Okay, now how to proceed? Yes. So our patients are getting older, and with this, of course, we have to treat older patients, and of course the demand of these older patients regarding good dental rehabilitation, the function of chewing, are also challenging us in our everyday practice. How to proceed? Yes. So with this, getting older patients means for us as dental treating doctors, we receive more sick people. And with this, of course, we get more patients with risk factors in our dental clinic. So if we look at the literature, about a fourth of our patients are medically compromised.
Dr. Mohammed, can you please mute yourself?
Can you hear me? For frequency of we have allergies, cardiovascular diseases, and diabetes as the most occurring diseases. And of course, a very high number of our patients are under anticoagulation or even under bisphosphonates. So about these topics, this webinar tonight will. If we look at the literature, what happened in dental clinics as critical incidents, we have death, we have circulation stop, we have myocardial infarction, we have asthma, we have syncope, seizures. So really anything can happen even on your dental chair. So how do I notice a risk patient? How do I implement some prevention preparation if I know this patient comes to my appointment? And what do I have to keep in mind before, during, and after treatment of this specific patient? So coming from the dental implant perspective, we have first risk factors for our implant success. On the other side, we have the risk factors for the surgical procedure, and this could be any kind of oral procedure. If we are looking at the implant success, very crucial is the soft tissue management or the soft tissue situation around our dental implants. So we have local factors, and Radiotherapy, smoking, further or prior operations, the hygiene of our patients are factors we cannot really influence as the treating surgeon. However, the surgical technique, especially regarding the soft tissue situation, this is something very important in our own hands. Systematic factors by the patients are its age or his age, the comorbidities, and of course some kind of immunosuppression because of organ transplantations or autoimmune diseases. Further implant risk factors, of course, coming from the implant inside itself, meaning the design, the micro design, the surface of the implant length and width. Oh, sorry very much. And of course, no corona. And the surgical aspects, and of course, our prosthetic concept we have in mind. However, almost all dental implants that are established in the market are really well proven to be safe and reliable regarding the long-term success. But the risk factors, and the most important risk factors in dental implants, is the history of patients if they had some kind of periodontitis before. And this is the reason why they lost their teeth. So this is really the highest risk factors that we have to identify, especially in terms of the informed consent of our patient. Smoking, diabetes, poor oral hygiene, and if we have no good primary stability of our dental implant, and if this happens then, or it's going on with a bacterial infection, the success rate is getting lower. For the long-term situation, we need stable, fixed mucous membranes around our implants. Additional factors, of course, patients are getting older. Some kind of genetics has been described in the literature, but are really not everyday routine to check for this. Osteoporosis, patients are getting older, more patients with osteoporosis. Osteoporosis can lead to cortisone therapy. Cortisone therapy can lead to osteoporosis, and then we continue with bisphosphonates. So we get some kind of circle of side effects regarding dental implant success rates. So can we treat patients with osteoporosis? Can we do augmentation in these kind of patients, or do we have them to keep them edentulous? Osteoporosis, if the skeleton is affected, it always affects the mandible as well. However, in the literature and my own experience say you can put dental implants successfully in this kind of patients. However, you have a higher implant loss rate in the upper jaw, but not in the lower jaw. There have been described some risk factors during the procedure of sinus floor augmentation because every structure could be very, very thin. So you have to take really care not to perforate the membrane. However, in total, the effects of osteoporosis seems to be less in comparison to smoking. What about diabetes? Diabetes has a risk potential for the surgical procedure and has a risk potential regarding the long-term success rate. Because if the diabetes is persisting for a long time, the vascular system of our patients can be really damaged. And they have an increased risk factor for myocardial infarction, some wound healing disturbances, cancer infection, and so on. And we have to know, and we have to inform our patient about that there could be a higher failure rate in dental implants in diabetic patients. Smokers have the problem that they suffer from periodontitis, which is the highest risk factor for dental implant failure, more often than non-smokers. However, the problem in smokers is that they show less inflammatory reactions and less bleeding during their periodontal problems. That means that the start of treatment could be later in comparison to non-smokers. So we have a far advanced periodontal damage situation. And of course, these patients are asking for dental implants at the same level as non-smokers. And again, we have to inform our patients about the higher risk factors of implant failure. If we look at the literature, there are several papers out that show significantly more soft tissue complications, peri-implant problems in smokers compared to non-smokers. However, smoking, even from the German dental implant societies, is not considered to be a contraindication for dental implants. But always we have a higher risk factor of implant loss, of wound healing problems, and of peri-implantitis. So we need to explain to our patients these connections. What about cortisone? If patients is receiving cortisone or glucocorticoids for a longer time, they can get osteoporosis, and osteoporosis can be treated with bisphosphonates. So we have two risk factors for our oral procedures: the cortisone-induced osteoporosis and the biphosphonates against the osteoporosis. What does biphosphonate really means to us? And we see really in Europe and in Germany a lot of patients with this kind of intraoral exposed bone. And the definition of these biphosphonate-related osteonecrosis of the jaw, BRON, or nowadays we are talking about medication-related osteonecrosis of the jaw, MRON, because it's not only this specific group of drugs anymore, it's more than this group. So we are talking about exposed bone for more than 8 weeks, a positive history for some of these drugs, and no radiotherapy in the head and neck, because then it would be considered to be an osteoradionecrosis, which is another disease. And of course, we have several situations how it could look like. And the clinical symptoms vary from swelling, from like some kind of jaw lock, from exposed bone, from fistulas, from just pain, from not healing after tooth extraction, and so on, so on. Always ask for this history of drugs and think about it. Consider this. And of course, the areas could be in the posterior area when you have a removable denture. It could be just on the alveolar crest, and you usually see this green color of the exposed bone because this is really an effect of the drugs itself. And usually it is progressive. Just wait and see. It will, if you make some mouthwashes, it will just prevent some super infection, but the necrotic area will usually enlarge. The diagnostics of choice, besides some kind of panoramic view or cone beam scan, is the MRI to show you really the extension of the necrotic area. However, there are two different, if we're coming back for the biphosphonates, we have the oral given drugs and the intravenous ones. And regarding their potential, they really differ. This is a slide in German, sorry for this, but just look at the column with the numbers. So you see that Someta has a 20,000-fold potential. Then looking at Didronil, which is a very weak action, a very weak biphosphonate. So biphosphonate is not biphosphonate, it really depends on the specific drug. So what indications do we see in these patients? Osteoporosis, as mentioned before, and of course, some kind of malignomas. So this means we have patients with a serious underlying disease receiving this very potential drugs. And this has to be considered when we are dealing with just dental or oral problems. And in summary, these potential drugs are really beneficial for this kind of patients. So biphosphonates are really incorporated in the bone. That makes the bone a little bit green, as you've seen on the picture before. The bone gets more dense, and especially in the mandible, the density of the bone makes the perfusion and the blood circulation within the bone reduced. So, and then the bone is exposed to some kind of oral bacteria, the blood circulation is reduced, and then the story starts. And biphosphonates really have a very long persistence in the bone. So what theories do we have for the pathogenesis of these BRONs, the necrosis of the bone? We have an excessive depression of the bone metabolism. We could get infections from the oral cavity, especially if we do any kind of oral procedure like tooth extraction. There are some theories about direct mucosa intoxication, and we have the effects on the vascular system. And if you look at the situation, the biphosphonates are really incorporated by the osteoclasts, and these osteoclasts are forever inhibited. Most important is to identify these kind of patients after or under therapy with biphosphonates, because the patient really does not know the name bisphosphonates. So you have to ask a little bit around. Do you receive an infusion every 4 weeks or every 6 weeks to get, if you have the idea this patient is one of these receiving ones, you have to ask specifically regarding these drugs. Because we have to differentiate our patients in a high-risk group and in a low-risk group. The high-risk group are not the osteoporosis patients. These are usually the oncological patients who receive this intravenously. And the low-risk patients are usually the osteoporosis patients receiving these drugs orally. And of course, an oncological patient who has bone metastasis has another prognosis than just a patient with osteoporosis. So the ideal situation is that you get this patient admitted before the therapy with bisphosphonates starts. So then you have to clean everything, and then the patient is ready for the therapy by the oncologist or whoever is considering. So you have to educate your patient about the risk of jaw necrosis for the rest of his life. The restoration of inflammatory lesions is up to you, smoothing of bone edges, finish any kind of prosthodontic work, intensify the oral hygiene of the patients, look at removable dentures, and establish a good recall with these patients. Contrary to patients after radiotherapy in the head and neck, caries is not the relevant prognostic factor in these patients, but the periodontal status, because with the periodontal disease, the infection can enter the bone, and with caries, the risk is not there. So dental treatment before biphosphonate. Extract all teeth with an unsure prognosis, especially after root canal treatment, periodontitis, periimplantitis. Complete any kind of periodontal treatment. In case of oral given biphosphonates, extraction in the first and second year is still considered to be possible. However, these kind of patients get something like a surgery deadline. Approximately 3 to 5 years after oral bisphosphonates, these are really risk patients. And if it's an intravenous one, after the first application of the drug, the patient is a high risk for developing a bone necrosis. According to the American Association, there are 4 stages of the disease. And in summary, stage 0, we have no bone exposure, but the patient has some symptoms. In the stage 1, we have symptom-free exposed bone. Stage 2, we have exposed bone with inflammatory signs. And stage 3, we have exposed bone with additional complications like fracture, like fistulas, and so on. In earlier days, the recommendation for the stage 1 and 0 was conservative, and for 2 and 3, it was surgical. However, nowadays, we tend to, even in the stage 1, meaning symptom-free exposed bone, we advise the patient surgery because we know it will progress. What does it mean if the patient is coming with exposed dead bone, as the pictures I've shown you? Usually we admit the patient to hospital. In our department, it's an inpatient treatment with discharge on the 5th postoperative day. We remove all necrotic bone under general anesthesia. We do a primary wound closure with tension-free suturing, and in the lateral parts in double layers, meaning in the mandible, we mobilize the mylohyoid muscle, and in the upper jaw, we use the buccal fat pad. And then, of course, the mucoperiosteum as an additional layer. We start the intravenous antibiotic treatment the day before surgery and continue till the removal of the sutures around the 10th to 14th day, till day 5, till the patient is in hospital. We give the antibiotics intravenously. We give a nasogastric tube for 5 days to prevent the oral cavity for any kind of food. And of course, intraoperatively, we remove sharp bone edges. And of course, we don't do any kind of bone augmentations in these kind of patients. Just an example, a 71-year-old man with prostate cancer with Someta, the most potent one. And this was the clinical situation, a difficult area, as you know. So under general anesthesia, we expose the area. And then in some cases, we use these autofluorescence, and everything that is black is dead bone. So you have to remove this, as you can see here. And then you see this green bone. This is healthy bone. And then you can continue with the plastic coverage. Here it was without the mylohyoid muscle because this is an older case. Nowadays we do it in double layers. Second case, a female one with breast cancer, also Someta. Not so obvious that there is exposed dead bone, but if you look at the image, there's really a defect in this area. And if you expose it intraoperatively, it's like a sequester, just 3 pieces of bone you can take out with the forceps. Again, we clean everything up. You see still that it's dark, meaning dead bone still there. So we continue until really it looks healthy. And now even the fluorescence imaging is looking better. And then we do the closure in the healing. So this is how it looks like. But then the question is how to rehabilitate this kind of patient with some kind of teeth or removable dentures. And here you see imaging before, imaging after, and everything is better. So what about if you stop the therapy of biphosphonates? There's really limited evidence whether it's really beneficial or not. In the intravenous group, it doesn't seem to have any effect whether you stop it or not. In the oral group, there are some papers saying it's beneficial and some others say there's no effect. Usually we try to skip 1 or 2 administrations of the drug to get it something like a gap where we can do a procedure if the patient is already under therapy. And then, of course, everything has to be taught. You have to double check with the GP or the oncologist that the patient is able to take a break or like some kind of a drug holiday. What about biphosphonates and implants? There are case reports and even animal studies say they are negative, they have no effect or even positive. So at the end, honestly, no one knows whether it's beneficial. The risk is if you go in for implants and the patient is under biphosphonates, you have to open, you have a surgical procedure, and there's the risk that the necrosis starts with your procedure. This is really the point you have to keep in mind. In Germany, we have a new guideline, or let's say a still valid guideline about implants in combination with biphosphonates. And the theory behind is that these patients, for example, has a removable denture, and by the pressure of the denture, the bone gets exposed and then necrotic and the story starts. And the point is, could this be prevented if you had put some implants before, that you reduce the pressure on the mucous membranes? That's the theory behind. And I just will explain to you, we have points that are positive for an implant and points that are against an implant. First is, do we have a high risk or low risk patient? Do we have necrosis in the history already, or do we don't have this? If we have a good oncological prognosis or bad oncological prognosis, do we have points of infection or not? Do we have sharp bone edges or not? How is our patient good with compliance or bad? How is the hygiene? And do we have really benefit if we have just a single missing teeth and the patient is under biphosphonate, please do a bridge. If the patient is edentulous and the prosthodontics is not fixed, then consider 2 implants and everything is getting better for the patient. So this is something you really have to decide very individual with your patient. And keep in mind today that it's not only the biphosphonates, there are other oncological drugs, especially these antibodies like denosumab, Prolia, and how these kind of groups, because they have the same way of effect with inhibition of the osteoclasts and the same risk to develop a bone necrosis of the jaws. And here you see examples. However, from the surgical point of view, the most important risk factor for us as surgeons is bleeding. And bleeding, of course, especially in patients under anticoagulation. And this is the next topic of my talk, how to deal nowadays with these patients, because we have a group of new drugs and we have new guidelines how to deal with. So, of course, the coagulation system of our patients has the aim to stop bleeding and enabling healing. And we have different ways how the body is doing so. And of course, from dental or medical school, we know this. It's a very complicated way how the body is realizing the coagulation. And we have a lot of drugs that are interacting with this system. So we have inhibitors of the thrombocytes, we have anticoagulants, and we have the NOACs, the new oral anticoagulants. And I want to explain to you a little bit the difference and how to deal with them. In Germany, we have around 1 million patients taking any kind of these drugs, so it's really a relevant topic. So if we look on the left side, you see the drugs affecting the thrombocytes. It's aspirin, and it's, let's say, clopidogrel, Plavix. So these are against the thrombocytes. The others are against any kind of coagulation factors. And we have the warfarin or Macumar, as we say, that affect several factors. And the NOACs are affecting only one single factor. And this could be the factor 2A, thrombin, it's by Pradaxa, or the factor 10A. And this is by the other new drugs. So against coagulation factors, we have to differentiate between several factors. It's the old generation, and the new generation is against only one specific factor. This is the new way of acting. And there are very high level, a little bit older patients out, why these new drugs are really beneficial to warfarin or Macumar. As you see here, it's against atrial fibrillation, and they have a reduced rate of stroke and embolism with similar bleeding rates. And the second patient, another paper, another drug, is superior regarding stroke, embolism, bleeding, and mortality. So that's why they are not cheap, and now they are in the market. And they have other advantages. They are affecting one single factor, as you have already heard. They have a significant shorter half-time. You have a fixed dosage for the patient. So one pill in the morning, or in the morning and in the afternoon, independent from the food is the effect. So no monitoring of blood values. They seem to be superior, as you have seen in the papers. And however, we have an antidote only against warfarin, Macumar, and Pradaxa. And for the others, we do not have up to now. So, however, even this, on the one side, we have new drugs. On the other side, we have papers out, and this is from 2015, that we should not interrupt the anticoagulation in our patients, as we have done in the past, because the embolic morbidity risk in patients with anticoagulation is higher if we interrupt the anticoagulation in comparison to the bleeding risk of the patients. And this is really new, to say, take your drug, I will do the surgery with your anticoagulation, and you as a patient and me as the surgeon, we both know it can bleed, but we will be able to handle this. And there are other papers out saying the same. So this is from 2018. So under continuation of the NOAC therapy, only a few bleedings. So we are doing low-risk procedures and so continue with your drugs. We looked at our own results with one friend of mine in private practice, and he did all surgeries as outpatients under local anesthesia, and he continued the anticoagulation of the patient. And he did osteotomies, extractions, apicoectomies, implant placement, everything. And he made suturing, he put some collagen into the wound, sometimes tapo-tamp or fibrin glue, and sometimes as protecting plate. So normal techniques we have available. And he looked. So after oral surgery with Marcumar, this is the German drug we are using, we have a higher bleeding risk, bleeding rate of 7.4 if the patient is under Marcumar in comparison to the control group. But it's not severe, and only 15 out of 637 patients had to be admitted to the hospital. The same surgeon, the same group. What about aspirin? Forget it. Postoperative bleeding rate the same if the patient is continuing with aspirin or is a normal patient. So no effect. So postoperative bleeding risk with clopidogrel, with Plavix, then we have a higher bleeding rate, especially if it's a double therapy with Plavix and aspirin, but still completely manageable. What about rivaroxaban, one of the new NOACs? Of course, then the bleeding risk is higher, 11.5 versus 0.7. However, still no problems for an experienced surgeon to manage the bleedings. So in summary of these papers, all bleedings were manageable with local techniques. We have the highest incidence of bleeding after or with these continuous Xarelto therapy. 15 patients with Marcumar and 1 patient with Xarelto had to be admitted to hospital. And the postoperative bleeding in case of antiplatelet therapy occurred within 2 days. In case of Xarelto, it could take longer, up to the 6th postoperative day. And in the control groups, usually on the day of surgery. And we have a new guideline in Germany about how to handle this. And of course, in general, we have to evaluate before the procedure, the individual bleeding risk. We have to consider points. Do we have the possibility of suturing? Can we apply pressure? What about the neighboring structures? What about our experience? What about the patient? So we have to differentiate our techniques regarding low bleeding risk, single tooth extraction, single implant placement, or high bleeding risk like an abscess or osteotomy of a wisdom. And regarding Marcumar, warfarin, for procedures, the guideline says in areas where we can apply pressure, continue with the therapy. If we have high bleeding risk or the patient should be sent to a specialized center, maybe as an inpatient. However, the Marcumar effect should be at a lower level and not exceed 3.5 ENR. What about Pradaxa? If we have a simple procedure, you can continue or you interrupt it for 1 day. If we have elective surgery, we should consider when was the last pill taken by the patient. And if we have a high bleeding risk, transfer to a center. What about Xarelto, Eliquis? Simple procedures where pressure can be applied, continue with therapy. Elective surgery, not earlier than 12 to 24 hours after last intake, and then you just make a small gap. And in case of high risk, send to a center. So really you have to identify your patients, what kind of risk they have and what maneuver or what surgery you want to do. In aspirin, many papers out, just continue with aspirin. What about clopidogrel? For simple procedures with monotherapy, you can continue. If we have high bleeding risk, you can transfer the patient to a center. If you have a patient under double or triple therapy, never interrupt this without consultation of the GP. And in case of double or triple therapy, try to postpone elective surgery until only monotherapy is necessary. However, what about bridging? Bridging means we stop the anticoagulation therapy and give the patient subcutaneous heparin. And bridging is really of risk because there are papers out, relevant new papers, that we have a higher rate of thrombosis in case of bridging, and they say there's no positive effect of bridging. So typical oral procedures like extraction, osteotomies, implantation should be performed under continued anticoagulation without bridging. In case of extended procedures or higher bleeding risk, bridging with heparin can be considered. Extended procedures where compression is not possible, or if we have a double or triple therapy, then you should really consider inpatient treatment. And of course, if the patient has a severe bleeding episode after surgery, admit him to hospital. Intraoperatively, you can use local anesthesia normally. However, you should think about infiltration instead of a nerve block, not to get any vascular damage in the pharynx. And of course, if we have granulation in the wound area, just take out all the granulation tissue to prevent postoperative bleeding. Suture is really the most important point to prevent postoperative bleeding. However, you can implant any kind of hemostatic material in the wound to increase the formation of the coagulation clot. Postoperatively, you can use tranexam acid, for example, 4 times per day as the mouthwash. However, how is the reality in Berlin where I work? And we looked at 150 cases of bleeding who were admitted to the emergency room. And they had 3 or 4 patients had a high blood pressure with adequate therapy, were high blood pressure patients with adequate therapy. A minority were patients with normal blood pressure, and some had high blood pressure without therapy. There are different reasons why the patients were under anticoagulation, and these were the kind of drugs they were taking. So half of the patients had bridging. You have already learned that bridging is out. We don't do this anymore. And 2% had Marcumar, clopidogrel, and aspirin in combination. So they were really a very high level of anticoagulation. So when they presented to the emergency room, 12% of these patients had really a massive bleeding. Intermediate bleeding had half of the patients. Most of the patients, or let's say half of the patients, had really a systolic blood pressure between 170 and 220. So that this can start bleeding now is clear. A third of the patients, of these patients, had not taken their regular antihypertensive medication on the day of surgery. Okay, sure, you can do this, but then the risk of bleeding is higher. And in the groups with intermediate and severe bleeding, 63% had a systolic blood pressure above 170. So how did the wounds look when they presented to the emergency room? As I said before, the suture is most important, but only 5% of patients presented with bleeding had a sufficient suture in place. Of course, you can make your life more complicated, but if you just suture it and take a little bit care, the risk of bleeding is less. Again, if we look at Marcumar or warfarin, 6% of the patients receiving Marcumar had an overdosage. 11% had an overdosage after bridging, meaning both blood values were at the therapeutic level or higher. That's too much. 34% of patients with postoperative bleeding are overdosed at the day of surgery, and then not taking the drug against their hypertension, and then the surgeon is not making sutures, then the patient comes to hospital. However, even the patients are specific, because 28% of the patients did not know how many teeth had been extracted. And even 12 patients thought bleeding was in the mandible, but in the mandible, there had no teeth been removed. So without wound management, or in this case, or insufficient suturing, bleeding occurs 2 to 3 hours after the procedure. If we put some hemostaticum alone, then the bleeding comes a little bit later. And in case of sufficient wound management, bleeding usually occurred without any specific time correlation. However, in most of these patients, Marcumar or warfarin was overdosed. So history is important. Consultation with the GP might be necessary in patients with this specific drugs. According to the new guidelines, continue with the anticoagulation in most cases. Bridging is only an exception. Suture is most important, and extended procedures or surgeries in the area where no pressure could be applied, the patient should be transferred to specialized centers like the Saudi German hospital group. And with this, thank you very much for your attention.
Thank you, Professor Max, for this valuable and interesting lecture. I have one question regarding the biphosphonate.
Yes.
Is there rule for the hyperbaric oxygen in these cases or not?
In Germany, we don't do this, and it's not covered by the general health insurance because they say that the evidence that it's really beneficial is limited. So in Germany, we don't use this. If the patient is asking for and is motivated to pay by themselves, and it's really an extended situation, we try this, but it's usually an individual try. It's not established.
After how many weeks we can insert a dental implant in these cases?
After necrosis, or after starting the biphosphonates, what situation do you have in mind?
The biphosphonate.
Yeah.
After when we can insert a dental implant?
It depends. If the patient has no necrosis up to the situation, you really have to balance the individual risk. If the risk is low and the patient would really benefit, like the edentulous patients, you can discuss with the patient and continue. If it's like only like a single tooth replacement, I would favor a bridge. If the patient had already necrosis in the history, then it could be really risky to put implants.
Yes. But regarding the INR, up to 2 to 3, we can start a surgical procedure or not?
Yes, I would say so. Yes, but again, it depends on the surgery, what you have in mind. If it's really like a wisdom in the for example, in the lower jaw, then you should consider this to do it as an inpatient, but you can continue, you can do the surgery under anticoagulation. If it's only like a single frontal tooth, you can do it under anticoagulation as an outpatient. So you really have to balance, but below 3.0 as an INR, you should be on the safe side.
Yes. Thank you. Dr. Kamal, do you have any question?
Oh, yeah. Thank you so much for that great lecture. I really enjoyed. I have one question about the local hemostatic agents in common use in the dentistry and in implant dentistry and oral surgery. What is your recommendation regarding this and in common use? The things that you usually use to control the local hemostatic agents?
Yes, usually I take some kind of, we call it gela stipped. It's a very small piece. It's comparable to the gel foam, but in small pieces. Gel foam is usually a big piece if you open this, and we use something like this, but in smaller packages. And this is usually what I like when I extract a tooth or remove a wisdom. Just I put, even in patients without anticoagulation, I like to have this to be really, to just increase the stability of my clotting.
That's very good. That's very good.
Even the gel foam I like very much, and I know that you have this available.
Yes. There is one question regarding what is the limit of diabetic patient for doing implants?
If the diabetes is under treatment, then it's no limit to go for implants. However, you have to explain to the patient that due to the literature, they have a higher failure risk. That's the point you have to discuss. But you can proceed with dental implants if the patient is under diabetic. Sure.
Yes. Dr. Hakim asking, do you have to repeat the INR the day of surgery?
If you want to be really on the safe side, yes, but usually we do it the day before or the 2 days before. But of course, if you do it on the day of surgery, you're on the very safe side. But it could be a little bit like an organizational challenge to get the result on time. But then you're safe. But it's not a must, in my opinion.
Yes. Okay, Professor Max, I would like to thank you very much for this very nice and excellent presentation. You are always giving us a new and profitable knowledge about the new in our field. And I hope to, inshallah, to visit our group, especially SGH Cairo soon. I hope so.
Would be my pleasure. Thank you very much.
Thank you, Prof. Thank you. See you. Thank
you. Thank you. Bye-bye.
Bye.
Thank you. Bye-bye. Bye-bye.
Okay.
Hey. Okay.
Thank you. Bye-bye. Bye-bye.
Thanks.
What's your name? Как тебя зовут? Как тебя зовут? Ну скажи, как тебя зовут, дочь? Дядя хороший? Дядя, как тебя зовут? Не бойся, дочь, папа рядом. Только первая. Майка, дочь, не бойся. Let me see, check. Просто посмотри. Посмотри. Просто покажи дочь. Папа посмотрит. I think it's okay because they will open it several times. Все. Finish. Доча, подожди, пусть посмотрит.